Welcome back. Let's talk about the cardiovascular system when awake at rest and its response to exercise. It's very difficult to appreciate changes in cardiovascular variables during sleep, anesthesia and exercise if we do not have a clear frame of reference for what those values are when awake at rest. By now you should be very familiar with the typical values which we frequently encounter, and these represent human hemodynamic variables at rest. Now, each and every hemodynamic variable has an accepted normal range, and in most of the presentations I have chosen a representative value within the normal range, but which has been chosen very carefully for ease of recall. So let's embark upon a brisk review of normal values for the more common cardiovascular variables for the awake individual at rest. You do not have to remember all of these, but you may find that you automatically remember them because you use them in your daily practice. But let's start with the easy stuff. The normal heart rate is 60 to 100 beats per minute. Systolic blood pressure is between 90 and 140 millimeters of mercury, and diastolic blood pressure is between 60 and 90 millimeters of mercury, with a mean arterial blood pressure between 70 to 105 millimeters of mercury. Now remember, this is for a hospital population of patients. These are the patients you will be looking after. Normal CVP and right atrial pressures are 2 to 6 millimeters of mercury. Right ventricular systolic pressure is 15 to 25 millimeters of mercury, and right ventricular diastolic pressure is 0 to 8. And mean pulmonary arterial pressure is between 10 and 20 millimeters of mercury. Pulmonary arterial wedge pressure is between 6 and 12 millimeters of mercury. Left atrial pressure, 6 to 12 millimeters of mercury. Stroke volume is between 60 and 100 ml per beat. Stroke volume index is 33 to 47 mils per square meter per beat. Cardiac output, 4 to 8 liters per minute, or 70 mils per kilo per minute. Blood volume, 70 mils per kilo. Cardiac index, 2.5 to 4 liters per minute per meter squared. Systemic vascular resistance is between 800 and 1200 dynes seconds to centimeters to the minus 5. Systemic vascular resistance index is 1970 to 2390 dynes per second per centimeter to the minus 5 per square meter. Pulmonary vascular resistance is less than 250 dynes per centimeter to the minus 5. Coronary perfusion pressure is 60 to 80 millimeters of mercury. Right ventricular end diastolic volume, 100 to 160 mils. Right ventricular end systolic volume, 50 to 100 mils. Arteriovenous oxygen content difference is between 4 and 6 mils per deciliter. Oxygen delivery is between 950 to 1150 mils. Oxygen consumption, somewhere between 200 and 500 mils per minute. And oxygen extraction ratio varies from 22 to 30%. Now, with all of the above said, let's see how some of these numbers change in varying circumstances. In general, most hemodynamic variables tend to decrease by 10 to 20% during sleep, more during general anesthesia, and they increase during exercise, but they increase in such an incredibly dramatic fashion. They can increase by up to 400% even in untrained sedentary individuals, and 700 to 800% in the most elite, highly trained competitive athletes. This is quite amazing. So let's consider the cardiovascular system response to exercise in detail. During exercise, metabolic rate increases, but particularly in skeletal muscle, and oxygen consumption increases proportionately. And the primary determinant of oxygen consumption per minute is the ability to increase your cardiac output. Naturally, from untrained sedentary individuals to elite aerobic athletes, the maximal cardiac output per minute varies a lot, and so it is somewhere between 20 and 40 liters per minute. And this parallels maximal oxygen consumption, which is between 35 to 85 mils per kilo per minute. cardiac output increases due to significant increases in both heart rate and stroke volume. Basically, maximal oxygen consumption cannot increase if more oxygen is not delivered to the tissues. So maximal oxygen consumption is limited by our ability to increase our cardiac output. So let's talk about determinants of cardiac output. The maximal heart rate for men is 220 minus age and 210 minus age for women. But this shows wide inter-individual variation. But maximal heart rate in a 20-year-old will be about 200 beats per minute. Consider a resting stroke volume of 70 ml in both the sedentary and the highly trained athlete. Both may reach a heart rate of 200 beats per minute, but the sedentary individual increases stroke volume to approximately 100 ml and generates a cardiac output of 20 liters per minute. A highly trained individual can increase their stroke volume as high as an unbelievable 175 mils, and at a heart rate of 200 beats per minute, this can generate a cardiac output of 35 liters per minute. A heart that fills to 100 ml left ventricular end diastolic volume can never have a stroke volume of 175 mils. So diastolic filling must be amazingly and dramatically improved in these elite athletes. This occurs by augmentation of ventricular diastolic relaxation, which promotes rapid filling, but it's also driven by marked increases in central venous pressure and pulmonary venous pressures, so left ventricular end diastolic volume and right ventricular end diastolic volume can reach about 200 ml in elite athletes. This is a remarkable, almost unbelievable feat, but with reference to the formula for the volume of a sphere, it can actually be achieved by an increase in radius of only approximately 40%, and an increase in myocardial fiber length of 25% will enable an increase in spherical volume of 40%. Now, of course, these are approximations because the left ventricle is not a sphere, it is an ellipse, and the cross-sectional outline of the right ventricle is a crescent. Another obvious factor in increasing stroke volume is a massive increase in myocardial contractility. If oxygen demand increases by increments of 3.5 mils of oxygen per kilo per minute, there will be a linear rise in heart rate of 10 beats per minute for each 3.5 mil per kilo per minute increase in oxygen demand. The heart rate response to intense exercise is triphasic. So there is an ascending limb, a plateau, and a descending limb, and the descending limb of the heart rate response to exercise occurs when duration of diastole is so shortened that the diastolic filling volume is less than the stroke volume, and so stroke volume and cardiac output must then decrease. Now, in the elite athlete, we see enhanced early diastolic relaxation and increased preload, which produces dramatic increases in left ventricular end diastolic volume. And similar adaptations occur in the right ventricle. Long-term adaptations to exercise training include left ventricular dilatation with a permanent increase in left ventricular end diastolic volume. But there is significant myocardial hypertrophy which also occurs, and this is referred to as exercise-induced cardiac remodeling. There are, of course, proportionate increases in respiratory function, such as increased maximal minute ventilation. These adaptations lead to dramatic increases in cardiac output during exercise, which drives an increase in maximal oxygen consumption. Patients who regularly partake of aerobic exercise training exhibit significantly lower levels of arterial stiffness. They exhibit greater resistance to systemic oxidative stress and inflammation, and they also show increased vascular nitric oxide production, leading to enhanced endothelium-dependent vasodilatation in the vessels of the microcirculation. And the cardiovascular adaptations that we see at a macro level are ultimately due to increased levels of vasodilatation in the systemic circulation on a microcirculatory level.